Good afternoon. I'm calling to order the Winnebago County Community Mental Health Board. Roll call. Mary Ann Abadi present. Dr. Edward Copeland. Dr. Terry Giardini.
Here.
Dr. Bill Gorski. Richard Cooner. Wendy Larson Bennett.
Present.
Tim Neighbors.
Here.
Linda Sandquist. Here. Mohammed Yunus.
Here.
And welcome to Jason and Chelsea and Nicole. And I want to welcome all of you and tell you that you've broken a record by being here today. We've never had this many attendees before, so thanks for the interest and hopefully you'll find it interesting. So moving on, we have no public comment requests, but we have two presentations. The first one is the Youth Mental Health System of Care. And are you going to be presenting?
Yes.
All right, why don't you introduce yourselves and take it away?
Yes, so also Joe's joining us, he's walking in, I just saw him.
Okay,
And I'm Alexis Rudishauser, she, her, and the Systems of Care Coordinator, working specifically on the Youth Mental Health System of Care project.
And I'm Lori Poppin, Director of Behavioral Health at Brightpoint, formerly Children's Home Aid. And we have been involved with the system of care work since before we got the grant. So I'm just here to help present on what we've been doing.
Yes, like I mentioned, Joe, he is going to also be with us. He is the project director for this grant, and also the vice president of crisis response services with Rosecrans.
Okay, just you have to do next. It's not.
Oh, I got it. There we go.
Awesome. Perfect. All right, so we wanted to start off, I know many of you are already kind of oriented to this due to previous presentations, but, oh, hey, how's it going? I can stand. Like, kick us off. Yes, well, we'll all stand. All right, so,
Sure. Yeah, my name is Joe Krell. I'm Vice President of Crisis Services at Rosecrans and also the Project Director for the Mental Health System of Care Initiative.
so we're just kicking off a little bit with just a general vision and sort of what we've done. We received this money from Illinois Children's Healthcare Foundation to be able to improve collaboration and communications amongst providers, specifically to kind of increase the level of engagement in youth mental health system of care services.
Sure. So the purpose of the program or the system of care is to analyze the current system. We did that through a lot of surveys, a lot of feedback from the community and providers to really try to see, to try to facilitate discussion about gaps and strengths in their current system of care as it exists from a mental health lens. So the point of what we're trying to do is take that information and create a collaborative, coordinated, integrated, and comprehensive system of care to support the mental health needs of youth that is equitable to both those without funding and with adequate funding resources. So we presented here about a year and a half ago, I'd say. And where we left off at that time, because this is a 4-year project that we've been doing for a while, we're currently at the end of year 3, it follows the calendar year. So last time that we were here, we kind of left off where we were utilizing, we were trying to create a network of referrals, a place where all the resources can be housed and accessed by referral agencies. We left off by creating a community of practice to really boost the competencies of the clinical staff that are providing services in the community, and then just informing the communities on the mental health resources.
So I was welcomed into this role as a systems of care coordinator in January of this year. One of my primary projects, which I hope most of you have already heard about, is IRIS, which stands for the Integrated Referral Intake System. IRIS, as you can see, it is implemented in many other counties throughout the state of Illinois, as well as other states, Utah, Kansas. But I have been privileged to be able to move this project forward in our community with the general hope and vision to improve collaboration and communication amongst agencies and obviously improve the connections that family have to support services that are maybe not very formal traditional types of care, but also some of those informal supplemental supports that could be really helpful for their family. I have hosted 4 community conversations. I and our team recognize the importance of collaboration and consensus building amongst the community, especially as we build a system that will be utilized by all the agencies and service providers. But those are just some general topics. We just recently finished our 4th, which is focused around community level data governance. And a lot of what we're doing right now is getting that consensus built, and then obviously rolling out the system. Pilot implementation with a group of 10 to 15, well, 10 organizations and 15 programs went May through August. And now we are in the community-wide implementation phase. So I know that I had shared with you guys sort of a report of that information. I wanted to make sure that all of you had some additional details related to who is currently in the system, who is onboarding in the system, who will be in the future. And obviously moving forward, we are wanting to create a very comprehensive and robust network. As I had mentioned, this isn't necessarily going to be a place only for those who provide formal traditional services, but also a place for people to get connected to supplemental support. So this is our guiding framework. Obviously, there's a lot of different components of this, but as we kind of build this robust system, we're looking at getting food pantries involved, churches involved, pretty much any place in the community, community centers, all that kind of stuff. Places in the community that can be helpful and supportive for people, no matter where they're at in their recovery.
So the community of practice piece of what the system of care is tasked with doing has been something that we've been talking about from the very beginning. And we have done some provider conversations. So those are open to anybody in the community. We come together, we talk about the different spokes on the wheel that was on the slide previous. So we sort of broke it into different categories, and with each of those sections of the wheel, we then went through a strengths, weaknesses, and optimal treatment kind of exercise with the people that came to the conversation meetings. And we got some really good information out of those. We took notes, we have data and narratives about information that was shared during those conversations. We've also implemented some evidence-based training opportunities. There's an attachment-focused treatment training that's going on with some providers in the community. That's something that we have found that it's been pretty time-consuming, so not everyone is going to be able to go into the actual certification piece of it, but they've gotten a lot of really good information and interventions that they can use in their practice. And then practice-wise, which is something that is through or offers clinicians evidence-based research around what works best for different situations in treatment. So they can go in and, instead of having to spend hours, combing through research on a particular diagnosis that they're working on, or a set of behaviors. They can go into practice-wise and find the research is already there, and they can kind of follow that. In addition, there's another piece to practice-wise called Match, which they can go into and really spells out like actual interventions that they can do with families and children that they're seeing. So that's a really great tool. We've got some people that did a pilot with that, and then we are opening it up to more providers in the community. So practice-wise, I think it's going to be a really great tool for people to use. And then moving forward, we're looking at hopefully offering some community-wide trainings, looking at some learning opportunities that, as Alexis was talking about just a little bit ago, they're sort of non-traditional, potentially doing, some art, therapy trainings, dance and movement kinds of things that are not, just your typical walk in and sit down at in an office kinds of interventions. So those are things that are still being, kind of developed, but we are, hoping to get more input through some of the community conversation information that we've gotten, and just by, reaching out to the providers that are already involved.
So just to kind of add on this, for our upcoming community of practice meeting, we've invited the Regional Office of Education, Rockford Ready, the Regional Health Department to just kind of talk about trainings that they see us needing as a community, and then figuring out how we can facilitate those trainings together. We know that a lot of these things happen in their own separate areas, and those events and trainings are helpful and beneficial, but the purpose of this system of care and the vision behind it is we're better together. Figuring out how we can collaborate, have agencies work together to facilitate a training, whether it's Rose Plants brings in a facilitator, Bright Point brings in, provides the venue, that kind of thing.
Then one of the other key components of the system of care framework is the concept of nothing about it. So we've been doing our best to really get community involvement, community input to help us create the system of care, to help us guide the programming that agencies are creating. Because traditionally the practice is agencies see a need, create a program, put it out there, and then wonder why the engagement isn't what it could be in a lot of communities. So it's asking the communities, going to them, getting people with experience to share their experience, to say, this is what we needed, this is what I received, and this is the ideal optimal system that we would engage in. So we're engaging a group, it's called the YES team, stands for the Youth Engagement Steering Team. We're engaging them much the same way that we were talking about engaging providers, where every piece of that pie, every piece of the model is being addressed independently with those individuals, just asking like, where are the strengths, where are the weaknesses, and what are we missing as agencies to help move this forward. So we have that going right now. They meet monthly, the YES team, monthly, sometimes a little bit more, sometimes less, but monthly, to discuss that process. They're invited to our steering committees with the agencies, and some have attended, not a lot, but some have, to be directly involved in the conversation and share their stories. Also forming partnerships or kind of contractual agreements with other agencies to assist us with getting that feedback from the community and really seeking solutions in the conversations. And where we're hoping to move towards is kind of taking this and taking it almost to the next level. We've been in conversations with agencies that specialize in parent advocacy and training work, such as COFI. What does that stand for? Sorry for putting you on the spot. I thought you knew it was going to be super impressive. So like an agency like COFI, who basically facilitates parent trainings to take parents, to train them in how to be parent advocates, how to have the conversation, and how to bring others in their community into the conversation to advocate for their own needs. So we're discussing how to allocate our resources to bring in agencies like that to collaborate with agencies such as like NAMI, who this is part of their mission statement, or other programs or other agencies that are doing similar work, how can we leverage our resources to kind of increase what they're doing, to then have better access to get feedback from the community? Because that's been the biggest struggle we've had over the last few years, is really getting a consistent and demographically representative group of community members to engage in this conversation with us. We offer stipends and reimbursement for their time. It's just really getting that engagement that's been difficult. So that's a huge piece of what we're wanting to do. And hopefully out of this, we build those collaborations and potentially boosted the capabilities of other agencies to continue to work moving forward.
Yeah, so, and just to continue on this, I think that this is a super important component of this grant. We recently attended a celebration where we interacted with the other projects who received funding through the Illinois Children's Healthcare Foundation. And so knowing that we have sort of been struggling over the years with kind of getting that engagement amongst parents, I see it as our responsibility to really facilitate and support them in the skill building and knowledge building in order to kind of have them be a part of the conversation and sort of wondering why they're not a part of it if they were never given the tools, the knowledge, the access to know how to participate and sit at the table.
So one of the other directions we're wanting to take this is we've already identified providers in the community who say that they're involved in, let's say, crisis intervention. There's a lot of agencies that work in the crisis outpatient realm or inpatient realm. We put it on a continuum. We've gotten their feedback. We've gotten the feedback from our pocket of lived experience individuals about that service line as well. What we're wanting to do next step is get more community representation in all the agencies to basically hold a listening session. Let's get representatives from the agencies to just listen to the community when we ask them, what services did you receive? Or what did you need? Not what did you receive? What did you need during the crisis, after the crisis, and what could have prevented it from a proactive stance, with the goal of the agencies then taking that information and putting together an actual collaborative system of care, as opposed to a competitive system of care, which is kind of what we see today. That's what we're hoping the outcome will be for this next year.
So I like to end, I don't see a clock, but in an effort to just kind of create a space, there are more than, I did include my business cards over on that. If you guys have any questions, I'm more than happy to kind of walk you through it.
I have sort of a, I guess, a broad question, and I'll just sort of lay it out. When you talk about I'm interested in the crisis outpatient response that moves towards the crisis inpatient response. I'm interested in what you learned so far about people with lived experience and providers about what are the gaps and the needs that you can see already.
One of the, I don't have it memorized, but one of the conversations that keeps coming up, or one of the data points, is that a lot of times when you're switching between agencies, for instance, or between levels of care, it's not exactly a warm handoff. And it's difficult a lot of times for family members to have to kind of start all over again with a new face and a new name and a new program and a new agency. And a lot of times that's where you see the fall off. So whether it's an outpatient crisis care trying to get them into an inpatient network, and then the inpatient network then trying to get them back involved in outpatient, there's a lot of hoops that they have to jump through because the lack of like data sharing, the lack of sometimes collaboration between agencies.
Just systems coordination.
And just coordinating it all. And sometimes we've encountered, we've talked to some families who basically said, like, the discharge process from a hospital, for instance, was, hey, here's a number, you should call it.
Yeah.
And that's it. And if the system were that easy to navigate, well, it's not. It's not.
Well, and then in that vein, so you have a child who's been put in an inpatient setting. What's the availability here in the county?
Not much, if any.
Somewhere between slim and none, correct?
More closer to none.
That's what I thought.
And it seems like some of the feedback that we got, even around like the physical location, like we got feedback about, you know, what the space was like when they were in inpatient. And so it was a very broad gathering of information about their entire experience. So from, the discharge piece to what was it like for you when you were there? And, what would you change if you could? So
Or even like when youth isn't inpatient, there could be much better collaboration for the inpatient working with that youth for medication stabilization services. But then another agency can be working with those family at their home to adjust that space. And another agency might be able to come in and provide some more non-traditional follow-up care. It's that lack of collaboration, and it's kind of like, you're involved in our services now, we are done with you, they are in your services now, you are done with them. There's not multiple, what you don't see and what we're hoping to accomplish is you don't see kind of a systemic kind of care team
Right.
for a lot of these youth. Sometimes that stretches across agencies.
Okay, so you're trying to knock down what I guess we have called the silos.
Yes,
between
Absolutely.
organizations.
and I think that Iris is sort of a structured tool where we can begin to do that. Obviously, there are a lot of partners on this. I've been very excited about the level of interest. We're still implementing this. I have some contacts who have implemented Iris in other counties, and it is sort of a slow rollout, but part of what I do is just empower them and remind them of this systemic change that we're trying to make.
How long have you been doing this? This program?
This grant was received by the community in December 2020.
Okay,
but we started before that.
Yeah, we started a couple years prior.
all right. How is it working? I mean, give me your general, because on paper, everything always looks good.
Yeah.
Everything always looks good. So my question is, and this is how I always look at it, the true character of how things are handled is your failures. How do you handle your failures in this situation? You've had them. So how do you handle them?
I was gonna say, moving forward, I've been collaborating more with these other projects that have received these funds. I mean, I think that each of the projects are different, but fundamentally their purpose is the same. So I've been meeting with them and also having very candid conversations with our grantor about how we can make measurable progress in the next year. That will not only be helpful, but sustainable, right? There's been a lot of discussion and a lot of reflection on my part as far as like what is easiest to sustain is not what needs to be sustained. So kind of just recognizing the shortcomings and then moving forward through it and trying.
But are you implementing that with the rest of your staff?
I am the staff.
Or you are?
I am the staff.
Okay, I'm holding you that.
Yeah, you can. You can hold me accountable
All
to
right.
that. Yeah.
Okay, all right. Again, I just want to see how you handle the failures,
Yeah.
because they do happen. This is
Yeah.
mental health, and, good luck with that.
And we've had quite a fair share of, over the years, instances where well-intentioned on paper, then executing it didn't really go to plan, didn't really have the outcome intended. And the way we've largely been managing that is kind of coming back to the drawing board, like what were you hoping to achieve? What did we miss and how can we do it differently? To Alexis's point, really reaching out to collaborate or to, I myself have reached out to several saying like, this is not necessarily my wheelhouse. Help me understand this better so I can do better with this program. And it's just not pretending like you're the smartest person in the room, I guess, for lack of a better term.
Well, I think an example of that was that they applied for this grant a couple of years before we got it.
I was involved in that.
Yeah, you
Right,
were.
yes, and we were told you don't have a system in place in order to get this grant and start the work. And we're like, well, we thought that was the whole point of the grant, was to put the system in place, but so we did it. So we got agencies together. We had a lot of involvement in the beginning for various agencies. So, the failure initially was just that we didn't have anything in place. And so we brought agencies together and had a structure then that,
Without any funding.
yeah, right. People just came together. There was no money attached to it. And then they applied and got the grant. So.
Well, Mary Ann said it's good, but I haven't.
Right.
So I guess
They progress.
Okay.
I guess my question to you would be, so you've been doing this 3 years. So what is your estimate right now of what it's going to take in order to get the system of service functional?
So I think of this project in kind of multiple pillars. As far as Iris is concerned, we have built sort of a sustainability plan. So that will be continued to move forward with one staff member being myself to make sure that that improves. As far as the other pillars,
I'm really trying to find the best way to politically answer that question, so I'm just gonna not worry about being political with it. I think that's something that we've really been racking our brains on the last couple of months, because we've kind of made the decision in the last 6 months to maybe change our focus a lot to become more actionable. Because some of the feedback we're getting from community members is that they're aware that we exist, but they don't quite know what we're doing. They haven't really seen an impact of what we're trying to accomplish. And feedback from others who have been, that's great, but like, so what? Like, what are you doing with some of the projects? How is this gonna actually implement change? And that's why today we wanted to really talk more emphasis on like where we're going from here, not necessarily focusing on what we can do. Because we've been collecting a lot of information, having a lot of conversations, but we've struggled with really taking action and implementing that. And that's the goal of us moving forward. We've already started that work with like Iris, with some of our training components, and now with actually developing more collaborative system of care models to address the needs of the community involving other agencies. So I don't know how to answer that question, because we haven't, I don't know at this exact moment.
Well, I appreciate your candor
Yeah,
because,
hopefully it didn't hurt us.
no, not at all, not at all. Because in a sense, our board is getting criticism also for lack of progress. And what you're identifying is exactly our reality. And that is, we came into existence with really nothing in the community to do an array of services, because obviously you're using our model, the community support program. So the difficulties you're running into are exactly the difficulties that we have in terms of, because not this, putting this array of services won't work until people become collaborative and cooperative between one another. And you're hoping that you would see something similar to what a good healthcare system is able to provide.
Exactly.
Okay, that you have transparency and honesty and collaboration and cooperation across, no matter who's taking care of the person at that time. So, okay, thank you.
yeah, I guess
You talked about evidence-based training. What are the key component of that training?
Good question.
It's, so the one that we're currently offering is an attachment-based training. Dr. Becca Weedman, who is based out east. It's a virtual training. I think they go twice a month. It's kind of like a class. Basically, they go twice a month. They have outside work that they're doing, but it's didactic attachment work is what they're learning.
And the purpose is to develop more clinicians who can provide non-traditional types of care, because we know that.
This is a traditional source of care, though. This version of what we're doing actually ends in certification in the evidence base. So the way we developed it was, the way we identified it was we sent a survey out to providers saying, what are the top 5 types of clientele diagnoses that you struggle with to get that feedback. And then we partnered with the Northern Illinois Center of Nonprofit Excellence to do some groundwork to find evidence-based treatment protocols that exist that fit the age range and diagnoses identified. And this is the one we started with, was there was a lot of feedback about attachment issues, about that we got about clinicians not sure how to effectively treat or manage individuals in an outpatient setting with attachment issues. So we started with this one, and this one is very intense, and at the end of it, you do get supervision for the year, and at the end, you are certified in this process, and you can advertise it as such. And the practice-wise match protocol that Lori was mentioning earlier is also an evidence-based model, and practice-wise is actually a database housed by the Department of Mental Health at the state level, and it's a collection of thousands of research articles that come out, and they basically pare it down to say, if you're dealing with like a 15-year-old with depression, and you're a female, you can type that in and it'll say, these are kind of the most, based on the research studies in their database, these are kind of the directions you should go with treatment. You know, whether it's school-based, office-based, attachment theory, trauma-based theory, stuff of that nature. And they actually took that to state level and made this match protocol that Lori was referencing that includes a lot of interventions, a lot of parents, education guidance pieces, all the way down to specific trauma work. It's a couple hundred pages in length. It's very detailed. And we've been working with a lot of agencies because not all the agencies we're working with are therapy providers. Some are probation, and they're like, how can we adapt this for our probation officers to be more trauma-informed and interact with families more effectively? How can we use this with some of our foster care case managers, you know, to be more effective in working with these individuals? In schools, yes, exactly, truancy officers, et cetera. So we're trying to be evidence-based, but be mindful of the scope of practice that the individual is using it should be within. I don't know if I can, hopefully I answered.
Yes.
Okay, well, we've got to get on to the next presentation. But Mohammed, did you have a quick question you wanted?
Yeah, I got, the reason I raised that question, that evidence-based studies might not be fully applicable to your clientele, depending, I mean, what clientele is, because the subject of that study might be different people,
No, it's true.
different culture, different value system. They can't fully apply to other people. That was my reason.
No, that's very fair, and it's an ongoing, it's a moving target that we're continuing to need to address what trainings would fit the needs that the community has.
Thanks.
Thank you.
Thank you so much. We appreciate it. Next presentation is from OSF Trauma Recovery Center. So you can introduce yourself and take it away. Thank you very much.
Hello, everyone. I am Teresa Daly. I am the manager for the OSF Strive Trauma Recovery Center. And I'm here to talk to you all about something that recently just happened and how that impacts our grant and with all of you. And so our main funding source, which is the, oh, I can't, how excited. Recently, our Illinois Criminal Justice Information Authority, which is our main funder, actually decided to cut all of our funding, which was our main source of being open. And what we were able to do is try and use the funds that we have available from Winnebago County to at least try to get us through until it seems maybe mid-December, and hopefully buy us some time to figure out how we can still stay open. And so I'm here to just tell you what sort of happened, how it happened, where we're sort of going with that, and to just show the impact and hopefully to gain support in any way, shape, or form. Not necessarily am I thinking we're going to leave with, well, you know, that we're being saved, today, but it's really to show how in any way, any support, we need that because we are doing impactful good work, and I know we are. And that's not just from me saying it, that you will be able to see that from clients and the community. And so, first of all, you know, back when I was hired actually in 2020 to implement the Trauma Recovery Center, we were supposed to all, the new Trauma Recovery Center was supposed to be $1 million. We never got $1 million. We were always given less than. And so we started at around 793,000 and stayed at that for the last 3 years. So it was a grant that was awarded 3 years, and we were to implement, and we were part of the statewide initiative to look at what trauma recovery centers can do in their services and anybody else who's offering trauma recovery services, and pull those stats together and give that to the governor, and that's supposed to be in 2024. So at the end of this fiscal year, they're supposed to gather all these statistics from all these different trauma recovery centers, or anybody that's saying that they're offering trauma recovery services, all those outcomes together to see what works, what doesn't work, whatever was part of this initiative from the governor. And so then in 2022, we got a new WCG director who has sort of pivoted interest. And it's been very strange and very unusual in this way that when we sort of had to meet with her, all the trauma recovery centers in Illinois, and we had to sort of tell her what a trauma recovery center was and what do we do. And she was very confused. Right after that, we noticed that a new funding opportunity was sent out. It was out for 2 weeks, and it was awarded shortly after that to a new community-based sort of trauma recovery center, and it was about $2 million, and it goes towards all to this place. It's called Live Free Illinois or Live Free Chicago, and they are tasked with starting 13 sort of community-based trauma recovery centers throughout Illinois. And so, and they're here in Rockford and all the other places that the trauma recovery centers are based at as well. And as of September notes, ICJ also increased their budget now by another $2 million, almost $2 million again. And we sort of didn't know where that was coming from, because we have been told that all trauma recovery center money is cut, and that's why they had to cut one, and they'll cuts are coming more for the trauma recovery centers. What we do know is that unfortunately they are so confused in thinking that the model of the trauma recovery center is completely based out of a hospital. We are not. We are completely community based. We've never been in the hospital, and of course we take referrals from the hospital, but we're not hospital based, and so that's where some of this confusion is sort of happening. So that's how new funding is sort of going to these similar trauma recovery centers. And so I just wanted to go over that this is who we are working with. We are working with folks that are 14 and older, residents of Winnebago County, have issues with PTSD. They are either a victim, a witness, a survivor of violent crime. They're not maybe in a therapy targeting trauma. And they're not actively having suicidal or homicidal ideation, because we are not 24 hours. And right now, we need them to try and be clean and sober, because we don't want to go through trauma without having some coping skills behind that. The unique services, my team of folks, you need to know are passionate because they go out and they create things that are passionate to them because, well, we all have lived experience right here in this room. And they are able to say, this is something I know needs to happen in the community because, you know, I've done this work or I've worked with these clients or I have experienced this myself and this is my passion. So you will see that we have trauma-informed instruction and reflection, which is evidence-based to get people to understand how trauma affects the body affects the mind.
I do that.
And that would be my, yes. We do the crisis intervention and we can try and see them, you know, during, yes, business hours, but our clients know that they can get a hold of their therapist because their therapists only have 15 people to see because these are extremely traumatized folks that we are working with. And so we have to give them the attention that they need. And this is also part of the model. We are doing a lot of work with domestic violence and stalking, safety planning and all of those things. But also we got into JDC, Juvenile Detention Center, and we started offering psychoeducational groups that are voluntary basis. These kids volunteer to come and they volunteer to get individual counseling. We do not work with folks that are mandated. So they volunteer to participate, which is huge. And any one of those kids that can't bring any of those materials back to their cell can tell you how trauma has affected them. They can stand up and tell the other kid that finally came, say, this is what you're gonna learn, or this is what we've learned in that class, because we have an excellent person running that group, which is Ladonna, and she's amazing, and those kids respect her. We have the same types of groups going on through comprehensive community services where they have their teens coming in for their program. And then we said, how do we collaborate? How can we help you? Because we know these kids have trauma. So we go in and we provide that trauma service, trauma education. We work with Family Peace Center. A lot of our referrals have come from the Family Peace Center. We do a lot of the public awareness events. And, you know, we're doing these things in very, you know, safe environments, but we also have an anonymous support group for first responders because that is huge. We cannot work just with one section. We try to heal the whole community. We try to remove all barriers, so we make it anonymous because we hope that in time they can trust us enough that they know they will get the care that they need to get them the therapy that they need. But we have to start that. We also, on the same day that I found out that we lost our funding from ICJA, that same day I was told we got funding to start a hospital-based violence intervention program at OSF in the emergency room, which would be the first of its kind because of the way we are set up as being so community-based. And these are two separate models that have been implemented in different areas in different states, but never together under the same umbrella. And so if, and I'm like, well, we need to be here in order to implement it. And so we have to figure out where to find this funding so that we can implement something that could be seamless for those that we serve. And that's what, you know, we were just talking about with collaborating and making things easier for clients. This is exactly what we would like to do is see folks in you know, the emergency room. And if they're appropriate, of course, refer them to us for the therapy piece. Yes.
Before you go on, can you tell them the difference of the community-based TRC that's coming and the types of patients that they will only see?
So so the new community-based trauma recovery center states that it is, first of all, they are all connected with African-American churches in each community, and those churches will then be the liaison or the person that manages the program that is to be in mainly areas that are dealing with gun violence. And that's their target is just gun violence. Whereas for us, you can see the type of violence is 45% domestic violence, 14% are multi-victimization, we have 17% child abuse, 30% of other, and then we have less than, but we have folks that are survivors of homicide victims. And we have a lot of high profile cases that come through, unfortunately. And 85% are female, and we do not stick with a traditional label of whether they are a victim or a perpetrator. If they identify that they have issues and symptoms of PTSD, and it's safe, of course, for all of us to meet, we will, because we need to help those heal. It cannot just be one section in order to heal this community from trauma. We see 67% right now are Caucasian, 25% African American. The Hispanic population has been hard for us because we haven't found a therapist that maybe can speak Spanish. So, and it's hard to have access all the time to our folks that can do the interpreting, because they're doing interpreting for the whole hospital and everyone else. So, and there's only 2.5, maybe two people on one here. Okay, so it's a lot of. That's not enough for even just the people in the hospital. We're obviously seeing folks 25 and older mainly, but they also 57% are indicating that they have some type of disability, which I was actually shocked at seeing, and that 26% identify as LGBTQ. And we have at least seen somebody somewhere, in Winnebago County, somewhere, we've covered 70% of the Winnebago County area. So we've seen them somewhere. And when I say somewhere, I mean on the street corner, I mean in shelters, I mean at the Family Peace Center, anywhere that is safe for us to meet, we will meet them. They do not have to come to our office. And in fact, 79% of the time we're offering it in the community, the service in the community, or by telehealth, because we opened in the middle of the pandemic. 31 months total, we've served 385 unduplicated clients. We have given them over 5,538 services. We have done 284 meetings, and most of those would be done by our wonderful Kira, who's our outreach person, who is our ambulance chaser. She's also giving out 633 pieces of information, brochures, whatever, to community members. So if there was a shooting, she'll be there, and she's giving out into everybody's mailboxes. We had one woman, elderly woman, who called and was crying, saying thank you, because I wouldn't know what to do, because it was a home invasion, and she was scared to death and didn't know what to do. And here our brochure. How nice. You don't have to seek it. How do you seek what? What do you do for that? Where do you go? I don't know. Public awareness events are 35. And this is the impact of our services. If you look at the American Psychological Association, it says there are 2 critical outcomes that are essential and necessary to show if our treatment is working. And it is symptom reduction and reduction or lack thereof of hospitalizations. What people have told us. 79% I was showing you were completed, our visits are completed, but also that I go down to 97% of our current clients state that they would refer someone to our program. 83% of our current clients report having a reduction in symptoms. 100% of current clients have not been hospitalized for suicide or homicidal ideation. And we have a lot of folks that struggle. 86% of discharged clients state that they would refer someone to our program. 67% of those discharged report having still a reduction in symptoms, and 100% of them have reported no hospitalization since CNS for like suicide or homicidal ideation. And we also do assertive outreach, which is that when we have someone that drops off of our services, we will reach out to them for about a month. And if we don't hear from them, we do 3 attempts. That third one, we actually leave a personalized card and we let them know that we're here for them no matter what, because we know working through trauma is hard. Because we go through the whole history with them of trauma. We're not doing one session for their assessment. It might take us 4 or 5 times to meet with them because they dysregulate, just trying to talk about their life of trauma. And we can give them time because we're not having to bill either, which is wonderful. And we can do that. We can work with them on safety issues. We can work with them and take our time and really dive into that. And so Kira, again, goes out and gives that letter, and we've had then an 80% re-engagement into our services because they think we care. Because we get a personalized letter. That's nice. We say we get it. We know this is hard. We're always here for you. Because there isn't a reason to not take them again. Financially, we now have a gap between mid-December to May at about $422,000 to operate. And we're trying to find, there's supposedly, TRC money at IDH level, at IDHS. We're looking at all the different places that we can apply for grants. Of course, this is not the time. Everything is closed, of course. I have reached out to the Community Foundation here in Illinois. We've reached out to our OSF Foundation and talking with them. And I do have ideas about fundraising because we know we can never just rely on grants. It's just not feasible. And so we are working on those things. But why keep us? And this is just so that you know that we help all, those who need to be served from all walks of life. We help fill the gap of needed mental health services here. We are specialty trained in trauma. We offer services in a unique way. We help fill the gap of needed providers here in this area. We are providers with lived experience. We have 139 combined years of experience. Myself, I have almost 30. We are providers who started the TRC in the middle of this pandemic and kept going. And we are the team who has accomplished so much in so little time, and that is the truth. I have an excellent team, and you need to know that and tell anybody you know, because they are amazing in what they do. And they're here, and that's who's here. They are amazing. I wouldn't be here if it wasn't for them. This team on the weekends are even talking about what they're doing and how they're supporting each other and how they need to be a team. One is sick, how can I help you? What can I do? Who do you need? How can I do this? Are you taking your break? Did you go to the bathroom? They're doing that to me too. And self-care, we're doing that too. They're an amazing group, and that's my spiel. And I did send this along with 19 letters of support from different agencies. I also sent my comments that are all anonymous, because you need to hear not just a total, but you need to see what they're saying. And its impact is amazing. I was shocked too when I did it, when I finally looked. The impact is amazing. So that's it. Any questions? Thank you.
Can I just make a comment? I'm pretty sure I was one of the evaluators when you applied for your funding, and I'm pretty sure I gave you top box ratings because I thought it was sorely needed. So congratulations, I think, on the execution of a difficult project. I guess some of the questions are more for the board, but I just want to ask, have you explored the question of things like insurance reimbursement to try and bridge this gap, Medicare, Medicaid reimbursement to sort of bridge the gap on a temporary basis, or?
The therapists can,
Okay.
but the rest of them cannot, right at this point in time, you cannot get reimbursed for case management, outreach, or anything like that. So you're still looking at a huge gap.
Okay, but there is some
there is some that you
small incremental.
But then we get into not being able to live towards the model of how we can really work with the clients, but we could work around some of that, but for temporary, yes.
Okay, so the rest is, I think, more for board discussion, but kudos to all of you.
Thank you. Thank you.
So when you said the new director pivoted the interest and focus compared to the program that you do now and the reason why they pivoted, what do you think is the main reason why they pivoted and the difference from your program to this program? And necessarily, do you think you could have been more effective to prevent them from pivoting?
So when, so the pivot is, they believe that the traditional model is all hospital-based because the two originals, there's a total of 5 TRCs that follow this model that came here in 2017, 2018 is when Peoria opened in Chicago, the suburbs of Chicago. And they are more hospital-based. In fact, Chicago, if you look at their numbers, they even put that they do not go into the community at all. They do all their services in the hospital. That is the original model, but when we came on Rockford, we're completely, we're not even in the hospital, we're completely out in the community. That was some of the confusion for that director, for the new director. And we tried to talk to her about that. And then I think that there is a huge push to make sure that funding is going towards communities that need it the most. And that you need people that are going to work in those communities that are very much, lived experience, very much, and they want to hire African-American male therapists to do the work in these communities. And that's what they're kind of advertising also right now, which is difficult for any of us, to find. And that's that they're trying to push that piece that we obviously have not found. We don't have a African-American male therapist at this time. We haven't been able to do that, but we've been certainly trying to get into the community distribution as well. The other question, I'm sorry, I got lost. Can you say what's the difference? The difference between the two is, one, we are based off of a model that has been in existence for over 20 years that has been researched. I'm not sure what model they are following. They're specifically going to work on gun violence. We work with any victim of crime. So that's a huge difference in itself. And so, and I'm not sure how they're going to put all that together. It's a different way than the way they implement it. So.
And the reason I asked, because when you described why they were doing it and where they were going, I'm not upset with the pivot. Because from where I'm standing, this is my first time knowing of your existence, and I don't see you all in our community. I'm the funeral director. I see it every day. I was like, it would be good to have some of your pamphlets in our funeral home. I don't know who to send those people to. They don't, when they come to us, and he's like, when I see the pivot, I was like, that's a good idea, because that's where they're at.
And my thing is that there can be 2 of us, because there is too much for any one place to take on. And I think that for 31 months, we might not have gotten to everybody, but I know we worked with Maurice West, and we were at his, we worked on doing public awareness on the West Side. We did that. Huge event, over 100 people came to that. It was at Crusader Clinic on Avon. We have tried to go to all the African American churches. I know we have a list of all of them that we've left pamphlets with. We had a hard time talking to folks. We really have tried to do a lot of stuff, but we haven't been here that long either.
Tim, I'm Amy. Right. So you make a really good point, and I think that both can exist. Most definitely, there's enough trauma in Winnebago County to go around. I've been down to the coroner's office a couple times and done some outreach. I've left them pamphlets for referrals. I've done check-ins with them. It's kind of a way to maybe be able to reach those families that unfortunately, you know, their loved one has been lost and the coroner's involved somehow. But you're absolutely right. The funeral homes are a good point of contact as well. Absolutely.
done yet.
Right, well, I've been to a couple, but only like by default, but I've been down to the coroner's office. They should be aware who we are and,
Yeah, you did like,
yeah, I can harass them again.
yeah, so, but very good point.
Also, like at the beginning, I know that we would go to all the roll call meetings with the Rockford Police Department on all of the different shifts. Talking to the officers during their like 10-minute brief, passing out our pamphlets, having them pass out our cards when they go to mental health calls, domestic violence calls, all of that. And I don't think you mentioned it, but we're also in the jail and we do groups, and I see individuals both at Winnebago County Jail and also at the Juvenile Detention Center in Winnebago County as well.
I'd like to share also, as I'm a psychotherapist on the team, and want to share that we believe that the community is in need, right? And there's a theme in the room, even with the previous organization that walked out, that we all want to work together on the same purpose, is to heal the community and provide care for the community. How we do it isn't always the greatest because we're all trying to figure out the gaps and the ways that we've done wrong and the mistakes that we've made in the past. And I think the theme is we want to work together, whether it's a new program or an old program, but let's figure this out together at the same table. And let's, wherever the money is going, let's do this together. And the community needs us. They need all of us, and they need us all to work together.
Sounds like a lot of overlap.
Yeah.
It needs to be worked out. I agree with you. It was a really good comment, really good comment. Didn't we do a site visit here? Didn't we visit you guys like?
Yes,
here? Yeah, I
you were the
too,
board member that went.
yeah, I too reviewed your proposal. Yes, God. Are you open 24/7?
We are not.
Okay.
There,
Well, the reason I ask
I
is,
would love that, but
well,
you know, I need more money.
but I ask because I would like to see something like that as a co-responder, working with local law enforcement agencies. I'm in the middle of some crap, 2 o'clock in the morning. I like to be able to put these people somewhere, but you can't do it if you're not open.
But they have to have the funds.
Yes, I understand. I totally get it.
I'm gonna suggest you also reach out to the state's attorney victim advocates. Because victims of violent crime are entitled to VOCA funding
Oh, we know.
reimbursement.
Yes, we know.
But that's a good place to start your outreach. And used to be the police departments had advocates. I don't know if they still do.
So, but the victim witness is what you're talking about, yeah, so we give the same information to the clients that they deal about victim compensation. And that is a very hard thing to get because, gee, as a victim, you have to remember to save all your receipts. And remember all of that, and even though you don't know that it's available, but once you're informed, you may not still be able to get it. Because,
Right.
Yeah,
Right.
so, but we do, everybody gets a packet of that information.
Well, I just want to thank you very much for your presentation. It was very informative. And certainly you know that the Mental Health Board has been supportive of your program because you were funded by us. So I don't even think that's in question. And your work that you do is very remarkable. So I just thank you for updating us and being here today to present the information.
We appreciate you.
Thank you.
You know,
Thank you for your time.
something else you might think about doing is reaching out to your county board members and suggesting to them that they need to fully fund the mental health board budget, which has been slashed this year for
Definitely.
no apparent reason.
We'll be getting to that.
Yeah,
Yes.
but I mean, this is where the, you know, the rubber hits the road. Citizens need to reach out and say, hey, we need this funding in our community. So, because there is great need.
Okay, thank you so much. Appreciate it. Okay, moving on, the monthly activity report. Jason, do you want to highlight?
Sure. I would like to highlight we participated as we have been in the youth mental health system of care conversations around the IRIS rollout, and we are one of 2 data managers for that. So we've created a kind of collaborative governance structure around what that data analysis should be and the frequency of reporting it. So I was excited to hear the presentation today. There was more with IRIS that could be reported on that I think you'll see in your handout. I know the board has been behind that. It's kind of been aligned with our updated strategic plan that will go forward in November. And I just want to let you know, we're still part of those conversations in a very active way. And then I'll say moving forward, I think it's important to highlight that in October 25th, we have a training in which we're going to roll out the communications toolkit. We appreciate all the board members' feedback and comments on that. That's going to go out to all the members. And so it's really targeted, that training, towards the communication and marketing directors and managers for each of those funded organizations. And Chelsea, what's the current registration on that?
So we have 53 registrations, and so all 44 departments that we've covered have are registered or are signed up for the virtual rain gate. So we have representation from every single, all 44. And some are bringing multiple people. They have grant managers and communications people. Anyone that's important to the communications and facilitating the information flow will be at that training, and we'll have opportunities for them to see the documents, speak with the communication specialists, ask questions, and really trying to help facilitate the communications for all programs as easy as possible from big to small. So
When is it again?
it is October 25th.
October 25th, yeah. And so if you are wanting to attend, Tim, I assume you're asking because you may want to attend, let me know, because I need to then figure out if it's going to become an open meeting and how we handle that.
What time is it at?
It's from 10 to 12.
We do have limited space for that one, so we might not be able to.
Registration.
I have that was sent out.
Yeah, we can
for
send out your registration information.
Yeah, and we can provide you more information as well.
Yeah. But really, we're happy that all the funded organizations have signed up. I think that's going to get everybody on the same page with cohesive messaging and branding, and really reach saturation of communication over the next year.
I just wanted to know so I could send it to the board members so they can see what's going on.
Sure.
So, because they don't know exactly what's going on the mental health board. So if they see this training, they can see how many organizations are participating, whatever, what's going on with the mental health.
Why don't we send them a just registration printout to show who's all signed up and what's happening. And that will conclude the things that I wish to highlight.
Okay, thank you, Jason. Moving on to our action items, I will need a motion to approve the minutes of our September 2023 meeting.
You got it.
So thank you, Terry. I need a second. Okay, any discussion? No. Hearing none. All those in favor, please say aye.
Aye.
Opposed, same sign. Moving on to the minutes are correct and accepted. Moving on to resolution authorizing funded program budget updates for program year 23-24. And Jason, do you want to?
Yeah, so we only have one. We're pretty early into that grant year, but we did have a situation where the change being requested was so significant it needs to be an amendment. And what this is for the Rockford Barbell program that you're all familiar with. The staff for that program declined their option to take healthcare insurance. And so that freed up some funding that they wish to reallocate basically into program expenses. So you can see that broken down in the resolution, and Elliot is here to answer any questions you may have. Appreciate Elliot for sticking through an hour of presentations to answer questions.
Was it your breath? They all left. Elliot, you think it's gonna work out better for you this way?
Much better.
Okay.
Yeah, so like the large amount of funds will help us collaborate with CCS, actually, Comprehensive Community Solutions, which will give us, a lot of support, and we will possibly collaborate programs, give our kids exposure to what they do and vice versa, give us much more long-term stability as well.
Okay. All right, good.
Thank you. Any other questions, Linda?
No, I was actually gonna make a motion.
Oh, please make a
Okay.
motion.
That we approve this resolution.
Okay, need a second?
Second.
Okay, yeah, thank you. This is money, so, a roll call. Mary Ann Body, aye. Let's see, yeah, it's the bottom, okay. Dr. Copeland, Dr. Giardini,
Yes.
Dr. Gorski, Dick Gunner,
Yes.
Wendy Larson Bennett,
Yes.
Kim Neighbors,
Yes.
Linda Sandquist,
Yes.
Mohammed Yunus.
Yeah.
Okay, pass. So you're free to go.
Thanks, everyone. Good to see you.
Thank you.
Thank you. Thank you for coming. Okay, moving on to our second resolution to amend the Winnebago County Community Mental Health Board fiscal year 2024 budget. Jason, do you want to highlight?
Sure. If you're not already aware, the Winnebago County Board, as part of their appropriations resolution, voted to amend the Winnebago County Mental Health Board fund amount that was requested from $31 million to approximately $12 million, with the exact figures noted in the resolution. And so while they do not have the line item by line item authority, they do have the authority to dictate what that appropriation amount is until the new law goes into effect January 1st. So for the time being, that puts the board in a position that we need to provide them a new budget for the year based on $12 million, not based on $31 million. One thing I would maybe like to note with that, if you'll see the new amounts, I tried to really look at last year's budget and say, what are the critical functions that without doing anything new, we have to maintain? And that is what you'll see here. With that, that leaves us $11.5 million for programs. I had to cut all the money out of the special project awards. That 11.5 million, if we look at what we've already contracted for out of our 20 million, completely obligates all of that funding. So there is, until there is potentially another budget amendment from the board, if you choose to do that in January, there is no ability to obligate additional funds based on this current budget. That is all tied up in contracts from the last round of grant awards.
So what does that do for our next year?
According to legal counsel, we can still launch a notice of funding opportunity and receive proposals, but would not be advised to make funding commitments until there is a modified budget. So I think we can keep moving forward with the things that we had discussed, which is the grant renewals, which usually comes out. We've done that November, December each year. The accelerator program, which we have gotten some feedback from legal on and would like to present a final version of that to the board in November. We can keep moving forward with all those things, but no additional funding obligations until we have a budget that would support that.
And on behalf of the board, I just want to inform you that I did put a call into Chairman Chirelli, and I will be having the actual call with him tomorrow morning. And we have requested a board meeting presentation that Jason and I will attend and answer questions, because the county board had questions about the amount of money in our reserves and also had questions about the administrative costs. That seems to, especially, Paul Rena on the board is very concerned that we are just paying way too much for administrative obligations. And, you know, we have met with him in the past and given him all the data that compares mental health courts in Illinois to our particular costs. And we by far are the leanest. And we're under our 10%. And so, you know, for accounting purposes, it's not an unreasonable amount that we're paying. As a matter of fact, for the 44 grants that we fund and the required oversight, we probably should be having even more staff engaged in this process, to tell you the truth.
When is that board meeting?
Well, I won't know that till I talk to Chairman Chiarelli in the morning. But I did talk to his assistant and she had told me that we could come to a board meeting. And we want the entire board. And, you know, we've done this in the past. We've given updates. And we kind of, you know, not done it this year, but they requested that we come and answer financial questions. And Wendy, as our treasurer, did so. And there were still unanswered questions.
Well, I have to, so I was asked to give a presentation, which was a surprise to me. But with the preparation that I received with Jason, I felt like I could talk at least coherently about how we have got to the place that we're at with a large fund balance. You know, that taxes were being collected prior to the board actually being approved by the county board, that the original budgets that were approved left a lot of money in the kitty, so to speak, COVID. And then the challenge of organizations that are launching new programs, trying to fill what their goals were in terms of personnel. And I talked about the plan that the mental health board is examining to try and address the fund balance in a responsible way that doesn't obligate us to continue to fund programs when we will no longer have ongoing funds. Because what we are seeing is an increasing percentage of utilization of the grants that we're getting. You know, so we're, you know, in the first year, I don't recall the statistic, but let's say it was half the money was used. That contributed to the fund balance. This year, we're in the 70%, 75% range. And I would expect that while new programs, again, will not expend 100% of their funds because they will have hiring challenges, among other things, our current programs are going to reach their 100% utilization of funds. And then apparently that was unsatisfactory. They wanted, and they asked about the percentage of administrative costs. And I explained that we thought this was using R1 as our administration of grant funding was much more efficacious versus starting a whole new sort of governmental organization that would require a location, things like tables and chairs and desks and phone systems and computers. That alone would have hamstrung the execution of what the community asked for, which was the provision of coordinated mental health services. So I pointed out how quickly we were able to launch by utilizing R1 and how they continue to provide top, in my opinion, top-notch oversight. And Mr. Arena questioned the need, since we were hiring professional services, the need for administrative oversight of those programs. my position is good programming absolutely requires good supervision. When you're just handing money out and then not looking at how that money is being spent and making sure it's meeting the criteria that has been set by the grant, you're setting yourself up for fraud allegations. You know, and to me, what I see is R1 and what I think is a wonderful staff coming in, asking hard questions, examining data, keeping things evidence-based, and keeping this board operating on a professional level. Later, Mr. Arena called me personally and asked that we provide him an analysis of the administrative costs for our funded programs. And I had a conversation with Jason about that. And at this moment, we don't have a way of discerning that. I mean, I suppose we could just go back to our organizations and ask, but I think that would require our board to authorize that kind of expenditure of money, frankly, to do that. And I don't think we have it as a line item in our budget to ask individual organizations what their administrative costs are. And my question is, what qualifies as an administrative cost? Are we talking about brick and mortar? Are we talking about secretarial staff? Are we talking about grant oversight? You know, computers and electricity? I don't know.
Yes, Linda.
I would like to address this from my background of being a grant maker.
Yeah.
For 15 years, I was on the Community Foundation of Northern Illinois, or I'm sorry, for 7 years, I served United Way Rock River Valley. For 7 years, I served the Community Foundation. I have never seen such meticulous grant making as I have seen not only this board make, but under the direction of Jason and his staff, and particularly the expertise of R1. As a board member, I am upset that the county board feels the need to second guess the way we are allocating funds. It's my opinion that the public, the people of Winnebago County entrusted us with this tax money and asked that we spend it directly on mental health in the county, which we know is one of our biggest issues. And that's what we're doing. It is bogus, frankly, for anyone to question the quality of programs being done by the amount of administrative cost. That is an old model that nonprofit agencies have been held to for decades, which is nonsensical. And again, I'll use the word bogus. You cannot tell how good a program is by the amount of so-called administrative oversight. So I just want to voice my displeasure with the board and with their questions and their allegations that we are not properly doing our job.
If given the opportunity, I think you should say that.
Yes.
No, I'm dead serious
I hope I
because,
just did.
well, you did via YouTube. Okay, but sometimes not everybody watches that. But what you just said about 7 years this and what have you, those are things that I didn't know you did that. Okay, and now that I do know that, there's a different type of, yeah, good for you. But I think that way you just said it needs to be said, if possible, that evening. You know, I'm not stepping on what,
Not at all.
okay,
Not
I'm
at all.
not gonna sit there, but.
Well, first of all.
And
we
Tim,
have
you know, now I guess I'll just yield to you over here. I mean, you are a board member, you're in those committees, you see what's being said and done. And
You're a liaison.
our liaison, there you go. And so, I mean, what you just heard here, I mean, you heard it. Sure, that makes an impact.
Well, it all goes back to what I've been preaching, you know, we know what we're doing. People that deal with mental health know what we're doing. People that don't deal with mental health don't know what we're doing. And those people on the board don't deal with mental health. And I was trying to say we need to get people that don't deal with mental health to see what we're doing and be able to advocate for us. Because if we don't do that, the voice of the people that don't like the mental health board is gonna win, because those same people don't see what we're doing.
And you
And so
said
that's the
this,
biggest issue, it's like people that don't deal with mental health, they pay taxes too, and if they don't see the benefit in what we're doing, they're gonna vote against it, and they're gonna listen to what.
To be honest with you, Tim, I don't think this tax will have a hard time passing a second time. I really don't. Because the mental health needs in our community are so serious. And we have just begun. What we have done with this board is created, and it's still in progress, a system of care. And it's so different from anything else that any board has to put together. We started from nothing, and we developed a structure, a framework, a clinical framework, along with all the protocol for the RFPs. We have a strategic plan that is open to the community input. We just got through that process. I mean, you're smiling, but honestly, it matters.
I know it matters, but this is a political playing ground, and they've started their campaign. And if we
I know they
don't
have.
play the political playing ground, we're gonna lose.
But they were
I mean,
against
that's
us
why-
to
that's-
begin with.
That's
okay.
right, that's why, if you look at politics, whoever raises the most money wins. They started their campaign, so we have to start ours.
But, and that's fine, I
Mhm,
mean, because,
mhm.
I'll jump on where Mary Ann is. We should not be, we as a board, we should not be surprised that when there's $30 million in a fund in Winnebago County, that you have board members who are interested. And the fact is that, okay, I mean, they've made their point, and it's up to us to come back and to do what Mary Ann just talked about. When we 6 people in a room at the medical school decided to even have a referendum, there was not a single solitary thing going for mental health in the Winnebago County. Okay, I mean, there were a few agencies in this community, like Rosecrans, that were getting a couple $1 million a year to do that, but nothing else. What we have taken on is to show a community what it's like when you put in an array of services, evidence-based, okay, that people with mental illness need in order to stay functioning within the community. That's what we're doing. We have 11 evidence-based services that we're committed to, of trying to implement into this community. Because again, it's been proven that that's what these folks need. Okay, now to do that in the amount of time that we're talking about is, I mean, it's ridiculous to think that we can implement such a system in 3 years. It can't happen. And particularly it can't happen when we have workforce kinds of issues that we have found ourselves with, in addition to some other issues that have popped up. So, I think we can, I hope everybody's is still committed and passionate about what it is that we're doing. Because again, I agree with Mary Ann. We do our job in terms of sharing with the community what it is that we're trying to accomplish. We have no words. We have no words.
And that's my point in making the arrangement for a presentation.
That's right.
Because I think that what we want to do is let them know exactly what our plans are for
That's
the
right.
reserves. And also answer any questions they have. And I think that is, I talked to the chairman of the finance committee, and he thought it was a wonderful idea that we would come and give a presentation to the whole board. Because he said he's very interested. He's a new chairman, and he had, his concern was, why do we have the reserves? More importantly, what are we gonna do with the reserves? And as you know, we have our special target, our special projects as a priority target. And we can explain exactly what the thought is going forward. And I think it's important that we answer the questions because they have a lot of questions and we can answer. We're very transparent. I mean, there is nothing to hide about this at all. And I agree with you, Linda. I think that's an excellent summary of, this board work. And I have to say, it's because of all of you and your dedication. I mean, you're not all mental health people, but for the most part, you have shown dedication and passion. And of course, with the R1 contract, we are able to be probably the most efficient that we could ever be in a million years. I mean,
We could not have done it as a volunteer.
we could not.
That's
It's an impossible situation without backroom support. I mean, everything that R1 is offering. So
And
So
to that.
I do have, I'm sorry, I have to leave.
that's
So will
okay.
you lose a quorum then?
Let us get through the action items. I mean,
That's the last one, right? Or just then the work plan? Do you want to vote? I mean, we have to. Correct.
yes, it is. And we have to, let me just go through. So if we have further comments after this is voted on, is that regarding this particular agenda item?
You can discuss whatever you'd like in discussion.
Okay, in discussion. All right, so given that we need,
I make a motion,
okay.
and we amend
Winnebago
our
County.
Winnebago County Mental Health Board's budget to comply with recommendations from the Winnebago County Board.
Okay,
I second.
10 seconds. Okay, roll call for this. Dr. Copeland, Dr. Giardini,
Yes.
Dr. Gorski, Deb Cooner,
Yes.
Wendy Larson Bennett,
Yes.
Kim Neighbor,
Yes.
Linda Santos,
No.
okay, Mohammed Yunus,
Yes.
and Mariana Body, yes. Okay. So. All right. Thank you.
I do have a question about,
We do have one more action item.
Oh.
That's the only thing. Can
hang
you,
on, Linda.
can we quickly cover that, Linda, before you step up?
Yes.
One more.
Sorry. Yep.
Okay, moving on to the fiscal year 2024 Winnebago County Community Mental Health Board Work Plan. Jason, you want to?
It's the same draft that was provided in the budget packet when we met in June. There was a draft at that point. We formalized that after the budget's final. I feel based on conversation we had, we can still move forward with our operation. We just can't obligate new funding, so I didn't change what we had already decided that we were going to do.
Okay,
All right, so I recommend that we adopt the amended budget
the fiscal year
for
work plan,
the fiscal year work plan.
I second.
okay, for 2020. Okay, you second. All right, roll call again.
There's no-
Just no vote.
Oh, there is no money, that's correct. Okay, all those, we don't need to vote. Thank you. Okay, all those in favor, please say aye.
Aye.
Opposed, same sign. Okay, thank you very much. So, thank you for
Yeah.
Thanks.
So next on the agenda is a discussion item, so we can revert back to the discussion if so
Next
choose.
question.
Sure.
Administrative cost. Who's the. And different people sees it differently. You should ask Juan and Joe. How would they define administrative cost? That's a key thing, and they think that administrator, this and that, everyone is part of administrative cost, which is not true. Or we can use the standard definition.
I think that's a good point.
You can say that how is it defined and how you define administrative. But he raised this question, Joe and Paul with me, that too much administrative cost. I told him no, it doesn't look like that way. And there are numbers you can get from neighboring counties, SAMHSA and other places to find out what the standard administrative cost is.
Now, comparing apples to apples, the mental health boards in Illinois, do we know exactly what the criteria is for all of these boards for the administrative costs?
Sure, what the administrative cost in that sense is the amount of cost to operate the program that distributes the funding to the direct service provider. That includes grant making, program evaluation, communications, hosting board meetings, all of those costs are what we've looked at when we've benchmarked. If you're looking at direct service providers, there might be then a different way of defining that because it's funding versus direct service, right? Two different
Well, and Linda
functions.
makes an interesting point, and I'm extrapolating what she said. Having worked on not-for-profits, one of the barriers for not-for-profits is nobody wants to fund what are termed brick and mortar costs. So things like, videotape equipment, computer systems, office furniture, HVAC systems for standalone buildings are not available for grants because that's a brick and mortar administrative cost. Well, I love that she said that was a bogus evaluation because what are you gonna do? Stand on the street corner and do psychotherapy? This is sort of a built-in aspect of human services. That's like saying, we're not gonna fund police cars.
It's the cost of doing business.
It's the cost of doing business. And it's reality. You have to have professionals skilled in fill in the blank thing that you're trying to offer. And they have to have a place to do their business.
But there is not a administrative cost.
Well, when you look up the term administrative cost, it can be,
It's the equipment. If you go line item.
Yeah.
it'll be equipment.
but that often is lumped into administrative costs. So.
And we really have to be compared to others
Apples to
here,
apples,
what
right.
we do, I mean, that to me is the only way that it would be comparable.
I mean, administrative cost pertains to staff. Period. That's the right. Nothing, equipment or building, capital, there's a capital, building.
Right.
And I would never argue with that. Because I've seen them work.
Okay, so last item, if anybody has any more discussion, no?
Yes, I'll make a motion for adjournment.
It's a good one. I'll second that.
Okay.
All those in favor, please say aye.
Aye.